case in your small group. Alrighty, so case number one, it's our 20-year-old young man. He's a student. He's interested in blogging and conspiracy theory. What do we see with this young man? What do you see happening with him? Anybody? He's lost weight. Thank you. He's lost weight. He's not sleeping or eating well. Correct? And he is a little bit paranoid that somebody's watching him. Yeah. He's not going to class. He's lost interest, perhaps, in his schoolwork. That might or might not be normal student behavior, but in this case, we'll say it's not normal student behavior. And what is the role of alcohol or drugs in altering his mood? That would be my other question. You know, what's alcohol doing at this point? Let's see. And yes, and he's showing bizarre and paranoid behavior. Okay. So I rather form this as a mood disorder with psychotic features. It's also possibly a primary delusional disorder, which is more in the family of schizophrenia. Schizophrenia would be a whole different other talk, but schizophrenia often has onset as mood disorders in the late teens, early 20s, so young adults. So where depression often shows up for the first time in young adults, so do the delusional disorders. Ideally, this young man would need care with a psychiatrist rather than a general practice doctor. But often in this day and age, with current health care and lack of enough psychiatry care in many communities, he might remain in general practice for his care. Please.
So what is the definition of mood disorder?
Okay, so mood disorder is a pretty broad umbrella term. Mood disorders include depression and bipolar. I didn't, in that little handout that's kind of going around and off to the side table, that formal criteria, that really busy slide with all of the fine print, that defines depression. It doesn't define bipolar, but it defines depression. And so if you can click off 5 of those points, you know, not sleeping well, not eating well, weight gains, weight losses, lack of interest in general activities, you know, you have to get 5, then that, and present for 2 weeks, that constitutes a mood disorder, okay? Let's see, next. Our next case was our 82-year-old woman who had recently had a stroke. What do we see happening here? She is, anybody, reduced memory? I don't know who had this case. I can't call on you. Oh, okay. No time, not enough time. Okay. I'll highlight a couple of things. Thank you. She maybe she feels a little bit badly about her speech. You know, maybe she feels a little bit unworthy, less worthy. She is thinking about death pretty frequently. She's planning her funeral. A lot of people would say, well, you know, she's 82 and she just had a stroke, right? Maybe that's normal, maybe. But honestly, frequent thoughts of death and dying, frequent thoughts of just disappearing, even the thought of maybe my family would be better off if I was just gone. You know, that actually constitutes a not normal line of thinking. And that's actually pretty indicative of a depression concern. A lot of people will say, but I'm just deep, you know? Seriously, I'm just deep. I think about death and dying, you know? I reflect on this. I'm philosophical. But honestly, fundamentally, thoughts of death and dying are not a normal situation. Okay. Or they could be deep. Okay. So I rather thought, again, that this lady has depression. Option A, she is showing more than the typical problems related to a minor stroke. A little bit of word finding difficulty after stroke, that's a pretty minor stroke. And just FYI, on the spectrum of stroke. Option B, in the elderly, we often first see reduced focus and memory, and that can point to depression. It's not necessarily a consequence of her stroke. Depression often shows up as memory loss. And the elderly often come in and they say, hey, I'm worried about my memory. I need to get checked out because I'm not remembering things. And one of the things we want to do is screen for depression. Maybe that elderly person is not, everyone's worried about dementia. Do I have Alzheimer's? And in fact, they're coming in and the first thing you really want to assess is for depression. After a stroke or a heart attack, the incidence of depression can be 50% or higher. So that means in my regular practice, all of 50% and more of all of my patients who've had a stroke will develop depression after the stroke. And then option D, yes, it's true, strokes can lead to memory loss, but in her case, you definitely want to try treating the depression before talking about dementia, before calling her condition dementia. Okay. This gal, 42-year-old woman, not feeling like herself. What do we see with her? Yes.
She's staying there all day.
Right.
And she's not doing the activity.
Right.
And she thinks about that.
Yes.
To wake up to a
Right. Right. So thank you. So she would stay in bed if she could. She cries. She's exhausted. She's irritable, and pretty much all of her behaviors that we've highlighted here do point to major depression. Does one of them point more to depression than the others? That one I would say is hard to tell. It's hard to define if any of these is the most indicative. Again, in my work, I find though that the ones that are most quantifiable, the ones that you can actually define the best, are sleep hours. You can actually ask people, how much do you sleep? And if they say, I sleep 3 hours or 4 hours a night, and then you ask them, what time do you wake up every morning? And if they say 3 a.m., and unless they're working the early shift at Boeing that starts, all those guys do wake up at 3 a.m. And so you actually have to be kind of careful because the early shift guys at Boeing will say, I wake up at 3 a.m., and that could be in their minds normal, but actually they are still having a sleep problem. So asking people quantifiable questions like, how much do you sleep? How many hours of sleep do you get? And what time are you really waking up is important. And then asking them questions about death and dying thoughts, again, I think is very useful because if they tell me, if you can like tease it out, do you think about death? Have you been thinking about the death of yourself, your loved ones? Do you think about just getting in your car and driving and not coming back? If people say, yes, I think about that, but that's normal. You say, no, that is not normal. And how often is that coming up? And you can pin it down, what happened a couple times this week. That's really not normal. And those thoughts are either there or they're not. So they're useful for diagnosis. Okay.
You tell them it's not normal?
Yeah, I tell them that's not normal. Okay, and that's, I think that's a helpful thing to invite people to accept that there may be something going on if they're not. Yes, Carrie.
The previous example, like after the older woman had a stroke,
Yeah.
it seems like there would be some normalcy to feeling sad about what just happened to you and going through a little bit of a path. I mean, if you're like super high and happy, then, right?
Sure, sure.
So how can that be abnormal?
That's a good point. Sure, coming off a major illness, yes, there's an adjustment time. There's grieving for what is lost, grieving for loss of function in a stroke. There is getting used to your new life. There is confronting your mortality and thinking about death and dying. These are all true. But But if you get all 5, if you get enough, if you get all 5 happening at once, it's not normal. It really is not normal. So, for instance, for my gal, declining family activities. Oh, you could say, oh, she's just self-conscious. She doesn't want people to know she had a stroke. She doesn't want to struggle with her speech. But if you put that on top of, she's thinking about her funeral every day, she doesn't want to go out, she's changed her life dramatically, she actually had a minor stroke, so her word-finding difficulty is not bad. And if you see enough of these folks, you kind of get a sense that normal recovery after a stroke, people do get back into their lives, get back to their activities as best as they are able to. They make those adaptations, they get back to the gym, they do their rehab, versus the people who are not able to recover. Not because of their stroke, but they're not able to recover because of a depression that's holding them back. So I agree. I mean, that's a good point. What's normal and what's not. Sometimes time frame, sometimes the degree. A lot of times it's the degree of function that's affected. How much of their regular life function is restored 2 to 3 months after a stroke, and how much of their regular life function is just out the window. They've just given up on going to the gym, going to their garden. Okay. Case number 4, our 24-year-old woman with the new child. What do we see about this young lady?
Well, she feels tired all the time.
Yeah, tired all the time.
She cries easily.
Yes.
And she doesn't feel enjoy with children.
Right. Yeah, and
I also have a history of
history of anxiety, some thyroid concerns in her past. Yeah. And again, I think similar to what we just talked about here with the 82-year-old woman, we could argue this. We could say, well, this is a really stressful time. This is a lot of life changes for this young woman. She's on her own. She doesn't have a lot of family around. The child seems cared for. The child's growing well. She's breastfeeding. So isn't this all normal? But I think the other question here is this young mom thriving? Okay. Another point is with her history for thyroid nodules, you do want to check her thyroid function. Pregnancy often causes changes in the thyroid, and you would want to make sure that her thyroid tests had been assessed. Social history is very important. You can imagine how young women who are isolated without family or friends in the community can have worsening depression. Certainly young women who are in abusive relationships are at very high risk for depression. Okay, so this was a hard page. This was meant to be not completely clear-cut. She does have postpartum depression. Again, as we said, very common. Up to 80% of young women who've had previous depression will have postpartum depression. Should she take medication? Well, that's again very tricky. She's breastfeeding, and that medication will show up in the breast milk, and therefore the child gets some of that medication. So it's a judgment call. If she was not bonding with the child, or if she was not able to care for herself or the child, then I think medication would be definitely needed. Looking at option C, she experiences what many young moms experience, but that does not make this necessarily normal. Option D, keeping young women well connected is important. Option E, yes, we should be checking her thyroid. That should be checked. Okay, more medical student stuff. Lots of treatments out there. I'll skip through this. Lots of medicines. Okay, frequently asked questions about medication. I hear this all the time. They are very legitimate questions, commonly asked. Will these medications be habit-forming or addictive? Will the medicine change my personality? People will say, I'm not crazy. There's nothing wrong with me. Why do I have to take medication? Will it make me a zombie? Will I gain weight? How long do I have to take this stuff? So a lot of reassurance goes into this conversation on medications, advising folks that it's not habit-forming or addictive. With medications, you do want to maybe step into it and then step off of them because abrupt changes can cause side effects and be uncomfortable. People need to be fully informed about side effects always, including weight gain, etc. medications are not intended to change a person. I generally advise people to look at how they've been feeling recently and advise them that, hey, wouldn't you like to feel better? Wouldn't you like to feel more yourself? So actually medications are really more designed to assist people to get back to being themselves. And that it's the depression or the anxiety that changes the person, not the medication. I try to reassure people, taking medication doesn't mean that you're crazy. It just means that you're using a tool to improve your health. Right. Sometimes medications are used short-term, long-term. They can be used in many different ways. And I encourage people to think of medication as a tool, along with identifying depressed thought patterns, learning new coping skills in therapy, being able to respond to stressful life events in different ways, all important ways of managing depression. I looked for studies on prayer as a treatment for depression. There are a lot of studies trying to identify prayer as a legitimate treatment for many conditions. Heart conditions, recovery from heart surgery, recovery from strokes, old people, young people. The studies are hard to interpret. Some say, yes, it helps, people heal better. Some say, no, there was no response to prayer. I like this comment I found from one particular study. Where does this leave us? Well, God may indeed exist and prayer may indeed heal. However, it appears that for important reasons, controlled studies cannot be applied to the study of prayer and healing. So it's hard to define on a study. Certainly we know that healing comes with prayer. There's so much value for any condition, maybe even more so with depression and anxiety. But you'll be hard-pressed to be able to prove that on a scientific study. All right, I will run through this really fast. So this is a 72-year-old woman with a couple trips to the emergency department. Not sleeping or eating well, she feels panicked. Did anybody go through this case? Yeah, what did you guys see there? Panic, yeah, she panics. And yep, she's restless, she's agitated. We'll go back. Right. All good things. So before telling this lady that she is having panic attacks, she should probably have at least one good medical evaluation, checking her heart function, her thyroid function, and screening for substance abuse. You do want to see if she's using any substances. Alcohol, cocaine, methamphetamines can all mimic these symptoms, and they're commonly used. A lot of these conditions will mimic each other, and people will frequently come to the ER repeatedly and get assessed for heart attack before they're actually diagnosed with panic disorder. All right. And then a quick word about menopause. Menopause and associated hormone changes are very common. They're commonly associated with increased anxiety, made worse by sleep disruption. All of these medications can be useful during menopause. Option C, estrogen, can take care of a lot of menopause symptoms. It's very safe in certain patients. Option B, depression medications that work for anxiety can also work for menopause-related anxiety. Helping with sleep, option D is useful. And then option A, the Valium medications, they work incredibly well for anxiety. We love them, but they work so well they can be very habit-forming, and they're meant for short-term use only. All right. Okay, so I'm going to give you a few of what I've given you before is pretty accepted information about depression. You'll find it in textbooks and so forth. From here on out, this is my opinion. This is not stuff you'll find in a textbook. Some possible misconceptions. If a person has plenty of faith, they will not get ill with depression. If a person understands Christ's love for them, he or she will not become depressed. Depression's for rich, privileged people with a lot of time on their hands. Most of us are too busy to get depressed. Depression is a modern society construct. If we live with traditional values and well-connected, we will not get depressed. Or I'm not depressed, or my loved one does not need help. Right? I think that in an effort to maintain normality in life, I think in an effort to just keep going with life, I think sometimes we will explain things that are happening, circumstances, with some of these thoughts. And I don't say that to make anybody feel like, to feel badly about this at all. It's just to highlight that I think that these are very common misconceptions. And I encounter this in my office all the time. Okay, some situations. I'm going to use Faye as an example. So a situation would be like this. I would say to Faye, Faye, I like your sweater. I think Ada has one just like it. And Faye, who's not depressed, would think to herself, oh, I look good in this sweater, right? But depressed Faye might think to herself, oh, she doesn't like my pants. Or she thinks I'm copying Ada. She thinks I'm copycat. Or I need to get rid of this sweater. Or why is she looking at me in my sweater? Okay? So an ordinary routine comment, Faye, I like your sweater, can, when a person's depressed, be heard as a really negative comment, okay? It can be very much misunderstood. And depressed or anxious Faye might think about this one particular comment for a long time. So this misunderstanding is not anybody's fault. It's really the depression talking. And so I wanted to encourage that as we live in community, that we keep engaging with people, keep connecting with people. Out of fear of misunderstanding, I think in my own Chinese upbringing, we are very careful about what we say to people. We don't want to offend, we don't want to hurt feelings. But I think it's important to stay connected, keep talking to people, don't be afraid to make those comments, even if it's taken with a negative, almost a misunderstanding. It's okay. Another scenario, Faye is offering to help with the nursery. She could be a little anxious. Babies kind of feel her anxiety, and babies kind of cry and feel jittery themselves. What to do about that? Should I ask Faye to serve somewhere else? Maybe not in the nursery? Should I wait till her anxiety is better managed and then ask her to help in the nursery? I would really like to encourage everyone to value and validate the worth of each person in the community, in the small group. If Faye's gifts are not in the nursery, we really want to highlight and invite her to share her other gifts. Maybe she's a great cook, maybe she can invite people over for a dinner party, maybe her gift is in hospitality, in technical support, whatever her gifts are. Maybe she can partner together with someone to lead the next Bible study, any number of things. If she would like to serve, I really suggest really searching out ways to include her so that she has the opportunity to connect with people and serve, even in leadership. Ideally, I would tell her honestly, and maybe even repeatedly, I would have to say this, that her gift is not in nursery service, but that her gift could perhaps be in hospitality or in another area. And even if she does not actually volunteer to serve, I might encourage us to ask her to serve. That's a way of showing care for her. That's a way of bringing her in and connecting her with the community. And I think that's a way of really encouraging folks who are perhaps struggling in one part of their lives, is to develop another part of their lives. And if she really wants to work in the nursery, if that's really where she wants to develop and that's really where she wants to grow, then I'm all for it. I would say try to find a partner who can match her skills in that field. Let's see, other situations. Okay, more opinions from me. Depression and anxiety are not Dao-Mei or Dulian kind of conditions, okay? I really encourage the church to bring our challenges out in the open. Whether those challenges are physical illness, a stroke, a cancer, whether they're emotional or relationship issues, financial struggles, whatever it is, when a community can share these experiences, we can be honest and transparent, and that really gives Christ a place to work and transform us together. I really think that Christ has a plan for each season of our lives. He's writing our story, and he longs to build all of us into wholeness, no matter where we are in that story. And I'm going to skip this. And one last thing. I'm almost done with my med student part. All right. And helping the entire group grow. Just a little reminder, this is my opinion, but the entire group can really benefit when we're honest and transparent about what we're really going through. Each experience gives Christ the chance to show his plan for us. And I think we can try to share the things that we struggle with. Again, troubled marriages, troubled parenting, depression, job struggles, you know. These things are not always easy to bring up, in my opinion, in the Chinese church. But I think it's all the more important that that conversation be encouraged. When emotional health and well-being are a shared priority, I really think groups can grow healthy together. Regarding emotional health, there's a small group study that you can do individually as well called I Quit by Jerry Scazzaro. I think it's a nice study that has to do with being emotionally well, putting some bad habits off to the side, and just recognizing those bad habits. Thank you, I see some nods. It's a good series. This slide also reminds me to tell you about myself and how I really benefited when other people were willing to share. So here we go. A couple years ago, I went through a divorce, and prior to that, I was going to marriage counseling. And I felt really alone. I felt really, in the church, I felt odd. I felt like a freak, and I felt like it really wasn't something I could talk about. And I really benefited when a sister in my small group started to share about how she and her husband were having struggles, and that they were going to marriage counseling also. And I got to tell you that when she shared that, it was huge for me. It was so helpful, because then I knew that I wasn't the only one struggling. So I think we can really have opportunities to walk together. It's all for his glory, and we have the chance to provide encouragement and support through our community. He brings us to bigger faith, and we get the chance to walk together. So, okay, that's the end of my portion. So at this point, everybody gets to take a break. You get to walk around for a few minutes, okay? If you have questions on those index cards, or you have some questions, please write them down on an index card, leave them on the side table, or hand them to me, and we'll take a look at your questions, and we'll try to answer them here later. And then when we come back from our break in about 5 minutes, Ada's going to share her perspective on these topics, okay? All right.